Right.
Now that we have, yes, take it away, Phil.
So I'll be fairly quick through the background so that we can have some time to discuss, because I have some questions at the end of this that I'm very interested to kind of hear your thoughts and to gain feedback into this project. So you could actually advance, and then you could advance through that. So this is our research team, collaborative effort between Yale and WashU. I think we can keep going because I'm going to kind of keep us on track. So just a little bit about Missouri. The state of Missouri is an ending the HIV priority state, meaning it's been designated by the federal government as one of 7 priority states in need of additional attention because of the burden of HIV care in both rural areas and in urban areas. In the rural parts of Missouri, rates of engagement is really a major problem. Engagement along the HIV care continuum are lowest in parts of Missouri, especially in the Ozarks and northwest corners of our state. Just to give you a few numbers of rates of engagement, we have very low rates of retention and care, especially among African-American men. Rates of HCV are also notably high in these areas, driven largely by injection drug use and sexual risk behavior. Every county in Missouri recorded an increase in overdose from 2020 to 2021 with rates that were almost doubling in some areas. And many rural counties, primary care is really the closest provider geographically. So you can advance the next slide. So in primary care has been shown in prior work to be very effective at treating patients with OUD at the front lines of the healthcare system. I'm not going to cover all of this, but really there has not been a lot of work done in Missouri and nationally to really look at attitudes of providers towards syndemics of opioid use disorder and HIV. And also, implementation is very low. I didn't include an additional slide here, but more than half of the counties in Missouri have no buprenorphine providers. Now, that may have changed some since we've reformed some of the waiver laws in Missouri, but implementation and scaling up is a huge issue, especially in the rural parts of Missouri, and especially among providers who are able to prescribe, but they're not prescribing. And this number has changed some because of the waiver. This number of half providers not providing buprenorphine has changed some because now we have the waiver restrictions have been lifted. So, so you can advance that slide here. So actually you can advance this too to the next one. I want to talk about identity and intervention stigma. So stigma being a kind of multi-dimensional construct. There is a lot of research that has been done that looks at stigma from the perspective of the individual. There's less that's been done among stigma that looks at stigma among providers and among community members, though that is changing rapidly. There is a lot of research coming out in that area. There's even less research that is being done that looks at this newer construct that I wanted to look at in this research study that looks at the intersection between identity-based stigma and intervention stigma. And the way in which we think about identity stigma, much more people are familiar with that. That is, perceived attitudes or perceived or anticipated responses based on one's identity, an internalized negative perception of oneself based on one's identity that could either be HIV or it could be drug use status, it could be substance use, it could be a variety of issues. Intervention stigma has been studied some in the HIV literature, but less in the larger context, and especially in substance use, though that is growing. Intervention stigma refers to things like buprenorphine stigma, stigma associated with naloxone, stigma associated with syringe exchange. And frameworks are really needed to be able to kind of bring this intersection together of identity and intervention stigma. And we want to also look at how does this intersection of identity stigma and intervention stigma influence provider adoption of harm reduction and OUD treatments. So you can advance this here. So to look at this, just to give you a little bit of context, last year I met and convened meetings with key informant and key stakeholders bi-weekly to kind of get an understanding. This was not research. This was just listening sessions I hosted where we had key members from the Missouri Rural Health Association, AIDS Project of the Ozarks, the Missouri Foundation for Health, kind of provide buy-in and support for our project. And the culmination of this work led to an R21 that we submitted, and that's what I'm going to be presenting and talking about with you today. Here, we discussed ideas about why are providers either unwilling or unable to implement harm reduction and adopt waivers. This was at a time when the waiver regulations were still in place. However, if you want to advance the slide, thank you so much. These are just some results that we had, and these are not results of research. These are what people told us were provider attitudes that we wanted to look. And I took these thoughts and put it into my grant. And what we heard was that it would fear that it would change the client population, negative change to the clinic atmosphere, a lot of intervention stigma around not wanting to have syringe exchange or other harm reduction interventions in place there. Because of it would change the clinic dynamic. Some incongruence with religion and values. There was a lot of, from the Missouri Rural Health Association, who I spoke a lot with throughout the planning phase of this project, a lot of articulation of like our providers reflect the values of our community. And in our community, we're not ready for these types of interventions yet. And so I took some of these thoughts and put this into our grant proposal and have been using it to inform the development of our early stages of this research project. So you can advance to the next slide. So the overarching objectives of this project was to investigate the impact of intersecting stigmas on attitudes towards adoption and behaviors among providers working in rural federal qualified health centers and rural health centers in Missouri. I'm assuming that folks have some understanding of what an FQHC is, but I'll just say these are health centers that are earmarked for federal dollars. They typically are in resource limited settings. They're very integral to delivering primary care and healthcare in rural communities, as well as low-resourced urban communities. They're actually very influential here in Missouri, in St. Louis, where I live, in addressing things like STI care. The first is a mixed methods project to understand the extent to which intersectional stigmas inhibit the technical capacity building that is needed to foster adoption. So we had one, it's a mixed method study. We had one aim that is a quantitative aim, which we're not really going to get into today much, but that was to look at the mechanisms through which intersecting drug, HIV, sexuality-based and intervention stigmas influence primary care providers' adoption. And we're looking at implementation science constructs here, including diffusion, acceptance, the second aim is to conduct in-depth interviews with key stakeholders to look at multi-level intersecting stigmas at the individual, provider, clinic, and community level, and policy levels to identify strategies and as well as to better understand stigma. We're looking at qualitative work with providers, people living with HIV and OUD, community advocates, and regional leaders in the field of HIV and OUD infection. And we're using the findings from this study to develop a conceptual model to build and test the impact of a stigma reduction intervention. So this is ideally going to be used and platformed with support from the Missouri Rural Health Association, who is actually working to develop a platform incorporating technology. And so we're hoping that this can be integrated into the development of that work. You can advance the slide. So this just is a quick overview of our recruitment strategy for the fixed choice surveys we're using. What we did was we looked at 112 counties. There's 491 FQHC facilities. This is changing because we are having some trouble recruiting adequate numbers from here. So we're working with Missouri Rural Health Association, who's been blasting out our survey, and that's been helpful. But we are piloting our survey, so we're still kind of making some changes to our quantitative survey. But more importantly, the in-depth interviews, we're looking at experiences of internalized and anticipated and intersectional stigmas, engagement in treatment. From providers, we're looking at kind of enriching what we're finding from the quantitative surveys. We're looking to understand norms and values, culture and social climate, training readiness and efforts. And at the community level, I really want to understand kind of how do public attitudes play into all of this as well. You can advance the slide from here. I'm going to kind of move us through. These are some of our measures. There's some intervention. This is quantitative stuff, but happy to have context there. You can advance from here. I'm not going to spend much time on that. Okay, and thank you, Zach, for making these great slides for our last meeting. This was extremely helpful. So in our qualitative surveys, we have not started, just to give you a sense of where we are, we have not started the qualitative surveys. We're in the planning stages of that. I have very little experience with qualitative research. Debbie is leading the qualitative research side of this work. I'm wanting to get more involved in the qual work. And so I have some questions that I wanted to ask to this group to kind of help me wrap my head around measuring some of our key constructs and goals with this project. So we are planning to go through kind of a transcription and rapid qualitative analysis method of analyzing our narratives that we record, and the recruitment of participants is going to be done in two different ways. One is through our actual survey. So we've already gotten a lot of people who would be willing to participate in these qualitative interviews. Virtually everybody who has, I've looked at the surveys, virtually everybody who's filled out the surveys have indicated that they would be willing to participate in our interviews. And then also through our key stakeholder partners, our community partners. So that's the Missouri Rural Health Association, the Missouri Primary Care Association, the Missouri Foundation for Health. They are very connected to providers and community and regional leaders in each of in the areas that we're recruiting from. So we're doing that kind of two-pronged approach is what I anticipate for our recruitment. So we can advance to the next piece here. So this tapped into some of the phases of our work. I'm not going to spend too much time on this now. We can advance from there. So our interviews, we are tackling these three different groups: community advocates and providers, people living with OUD and HIV, and regional leaders. And we want to do this in such a way that, of course, the information that we're getting is feeding into each of these groups, and that we're using each to inform our analyses of each. So I had initially proposed this as a sequential explanatory model of mixed methods work in which the qualitative followed the quantitative. But one of the reviewers' critiques, and I would say is very legitimate, was that how are you going to do that in the time that you have available? Like, you should just start both. And so we are doing that. You can advance to the next slide. So providers, our eligibility criteria are prescribers. It was a waiver criteria, but actually we got rid of that requirement. So we're looking at anybody working in these federally qualified health centers. We're looking at our major goals here. I've covered some of this, so this is a little repetitive. So you can go to the next slide. And I'm going to just kind of breeze us through a little bit here because I wanted to have enough time to discuss this. So these are with our advocates. The Missouri Rural Health Association has a connection with a lot of regional advocates, specifically in the primary care space. So we'll be recruiting through there. And I really want to understand kind of what are the impacts of some of these policy changes that are happening on local ground level implementation and the delivery and the quality of services that people are receiving. In addition to that, we're wanting to look at how do some of these other marginalizing forces, such as homophobia, racism, and stigma towards people who use drugs, impact the delivery of services in the primary care setting. Traditionally, primary care has been reluctant to implement evidence-based treatment for substance use disorders. We really only have one FQHC in Missouri that has taken the lead, and that's Jordan Valley Community Health Center that has really taken the lead in implementation. And that's because of a lot of community advocacy in that area. So you can advance to the next slide. So for people living with OUD and HIV, we are going to recruit a number using our partnership with the AIDS Project of the Ozarks. We're going to recruit some folks that have OUD and HIV, some individuals who have just OUD, and really looking at this intersectional perspective of understanding the interaction between identity-based stigmas and intervention stigmas. And I'm really interested in understanding how narrative experiences of internalized stigma shapes willingness to access care in these settings. So one of the bigger challenges too is if folks do decide to implement these services, there is reluctance on the behalf of people who have opioid use disorders to go and seek services in these settings that oftentimes have lots of stigma associated with it. We see similar to this in the pharmacy work that I'm doing as well, that pharmacies can have a lot of resources, but people feel very much reluctant to access care in those settings. So we can move to the next slide. So community leaders, and this is not the order that we're going here. Debbie and I are going to kind of consult closely to see what order would be best to talk to folks, but I would say that we're not going to approach it necessarily from the order that these are being presented in. But for community leaders, I'm really interested in understanding what are the barriers in addition to stigma. So not only stigma, but in addition to stigma, what are the logistical barriers that are perhaps providing a larger context to this problem? And that can be regulations, criminalization of HIV, which is a massive issue in Missouri, and treatment practices, mandated treatment policies, PrEP reimbursement, provision, these different issues I'm hoping to tap into with the community leaders. We can go to the next slide. Oh, okay, so directly to questions. I thought I had one more, but so I do have some questions that I thought would be helpful because I have more experience with measuring many of these constructs from a quantitative standpoint. I'm interested in looking at what perhaps frameworks or recommendations might you have to capture attitudes and provider community attitudes towards syndemic of HIV and opioid use disorders in rural settings, maybe examples of like model literature that has looked at both of these, because I'm finding there's some work in the HIV space, some work in the OUD space, but there really hasn't been syndemic frameworks put forward for measuring kind of the things that I'm wanting to measure in this study. Also suggestions for qualitative approaches to measuring intersectionality between intervention stigma and identity stigma. Also strategies for measuring diffusion of innovation in rural context, any ideas that you might have there. And then strategies for presenting these findings to community partners, because a big piece of this is we are going to have at the end of this presentation of these findings to our community partners, and I'm open to hearing kind of suggestions about that. And then ideas about measuring, I kind of touched on that, that's a little repetitive, but measuring the kind of intersections between these different pieces is really kind of, and we have, Katie is a expert in this area and is bringing amazing insights so far. But I guess I'll leave it at that and open it up for questions. I wanted to have about a half hour in case people wanted to take as much time as we wanted to for questions.
Thank you, Phil. Before you did a lovely job, but there were some questions that at least I had, I don't know if others had, that would help clarify for me how to answer some of your questions here.
Yeah, please do. Yeah.
The first thing is, I feel your pain on, well, two comments. I feel your pain on the concurrent design because, yeah, in an R21, it's not the design that drives the choice. It's the timing and resources. Often, most often, it's, there's a lot of concurrent where perhaps you shouldn't be doing concurrent, that it would be more useful to you to do an explanatory sequential or exploratory sequential. But that being said, I was kind of a little confused about, you're still kind of developing the survey, you're changing it. And you know, the quantitative, for me, my understanding is you usually have your measures decided before you go into the field and start collecting data. So I'm not sure what that means exactly in this study.
Measures, I was talking about the quant side. We have not developed the in-depth interview instruments.
That's what I'm asking about.
Yeah.
My understanding
So,
is
yeah.
quant, you usually, it's done. It's decided before you start.
Well, first off, I would prefer that greatly. But there's been some significant policy changes that warranted changing of our survey so that people would not be like, well, wait a minute, I don't need to worry. So all of our questions were designed initially on the waiver requirements. So we had questions in there that said, why are you not, you know, what are the reasons? Select one of the for your decisions about whether or not to be waivered. Or for example, are you a waiver provider? The other issue is that time has been a burden, and we do need to kind of continue to shorten down the survey, because as we logistically see the time, we have a field that people can put in feedback, and time was something that was continually coming up, and we had a couple of abandoned surveys. And so as a result, we have been wanting to narrow that piece down. So there's one more reason why. So there's a few reasons why that made us so that we wanted to do it this way. The third reason was because there's new measures being published and developed that are shorter and to the point of what we wanted to measure with intervention stigma. Rachel Winograd, if you haven't heard any of her work, she does a lot of work in the medication first area of work, and she's come out with measures for looking at naloxone and methadone and medication stigma that are really great. And we want to be able to include those because she has a larger population here in Missouri that we can validate that against. We can do some really interesting things with that if we collect data from primary care, because she's collecting that from specialized care providers throughout the state. So there were a few reasons. I agree, it's not ideal, but we haven't gotten very far into our quant. We only had 25. I think we're close to 30 people who filled it out. So
it will be interesting to see how you wind up by analyzing that data.
I know. Yeah, good point.
The other thing that I wanted to kind of encourage you, or not, that you shouldn't discount your expertise in qual. Being a social worker, you're primed. You are primed for the system. So don't discount yourself and your qual abilities.
Well,
that being said, do others have comments or, with his questions? It's really lovely.
Thank you.
I mean, I have a question for, I guess I'll just say, I'm very pumped to see another social worker in the meeting. So hello. But I guess I was sort of looking to understand, in your questions, you ask about qualitative approaches to measuring things. Could you sort of talk about that a little more? Because we're not known for our skills.
Yeah, and that's a good question. Yeah.
I was uncomfortable as well.
Say that again. What did you say?
I was uncomfortable with that as well. So
I probably shouldn't use the word measures. I should more like look at approaches, because or how to ask some of these questions. And I think because in quantitative work, you can look at just an interaction. You can also look at a number of different methodological approaches. Here, the context, I think, is going to be about how we go about eliciting those narrative responses from folks. And I don't have a lot to go on in what I could find in the existing work. And this is we're going to be deferring some to Debbie to help with this piece, but thinking about this from a content standpoint, the approaches of qualitative work, I think we have a lot of that represented in our team, but the content of ways in which people have gone about measuring these types of syndemics. I've seen some, for example, in the literature around HIV and intimate partner violence and some of the other work around syndemics there that has done some of this. But I wanted to see if people had ideas and strategies that one could go about. So taking away the word measures, thinking about strategies or approaches to measuring syndemics in this context that might be helpful when we're going and approaching our design of our in-depth interviews. I hope that clarifies a little bit what my question was.
Yeah, no, that's helpful. Yeah, I mean, I'd definitely be interested in hearing what folks have to say. And yeah, I mean, my first thought, this is probably a very elementary suggestion, but like my first thought is just test the guide, like write the questions based on what you can find and what feels relevant with other literature. But any opportunity you have to sort of test your questions out is always really helpful. I know it's a very fundamental thing, but running 2 to 3 test interviews is sometimes invaluable in that process.
Sure, yeah. Thank you.
Yeah.
Gabby, Deanne rather. Deanne, did you want to say something?
Yes, sorry, I thought I was unmuted. And I apologize because this could be really a basic statement as well. But when I was reading these questions that you posed, I was thinking maybe a qualitative approach that was really theoretically driven might be a good approach, because syndemics theory has certain constructs that maybe you can, work into a code book in some way. And the same with diffusion of innovations. There are different concepts within diffusion of innovations that you could code that a lot of people have used the theory in general as a guiding framework. Maybe not for this specific topic. But just yesterday, I was talking with a colleague of mine about, he was working on something related to intersectional stigma, and about how so often when people are measuring like intersectional stigmas, they're really measuring the co-occurrence of stigmas. And rather than, rather than like the summative nature, rather than the actual intersection producing more than the sum of two things. And that's a lot of quantitative words to be using in this meeting, but you guys know what I mean, like even qualitatively, just putting things together. And we were talking about how it might be beneficial to do like a case study approach where you have you create a template, kind of like people have for the rapid qualitative analyses now, but you go through your interview and you're trying to, I just talked to him about this yesterday, so we haven't thought through it all, but you're trying to kind of match to understand that person's lived experience. So you can see if it truly is intersectional or co-occurring within their life, and capture like, what is this that's actually, what is the increased stigma? And the example that I kept having in my research was people getting tested for HIV. So when they went to get tested for HIV, there was a level of stigma at these health centers in Kenya where I was working. But if they were gay and getting tested for HIV, like gay, bisexual, or another man who has sex with men, then it wasn't just the stigma of being gay and HIV. It was really heightened because of this like societal belief that people who are gay are perpetuating HIV within Kenyan society. And if you couldn't just have those two alone, so in those cases, when I was reading through those individual interviews, I'm like, okay, I can see where this like addition of the intersection is, versus when I had coded the same interviews prior, and I had codes kind of capturing the separate stigmas and seeing when they're co-occurring, but it wasn't giving me the information I wanted. But those are just random thoughts.
Well, that's like really, sorry, go ahead, Laura. Sorry.
I have a question for Deanne on that, because that's an interesting, I've not worked on this and I've not thought about this, but I would want to ask your thoughts on, is there one or more ways to co-occur and to intersect? In other words, are there more ways to get to, oh, this is intersectional? The lived experience can be different for people Or is it the same, usually the same thing when it's an intersection versus a co-occurrence?
Yeah, so for us, we haven't gone through all of those narrative, like that was our idea that we came up with when we were talking about this issue. So we haven't applied it in a research study yet. But I think in my mind, the difference is co-occurring, it's just like a summative thing, whereas intersectional stigma, there's typically like additional stigma on top of it, where it's greater than the sum of the parts.
No, I get that, but the issue or the question to you is, are there more than one way to get that to that, particularly the intersectional, that can it manifest itself? And I guess that's a different question, and I'd love to hear a presentation on it when you do that analysis, you know, that there may be more than one way.
I think there definitely is. We were looking at outcomes, like our outcome of interest and how each of them impacted the outcome. But I mean, you're totally right. There's so many intermediary outcomes that could happen, like mental health, you know, before HIV testing, which is our ultimate outcome. I mean, it's so complex. I'd love to hear what other people are doing and what they think.
Sorry.
And usually the compounding piece is in reference to one's experiencing of the stigma. And so there's even less on the compounding piece in terms of one's enaction of that stigma, so to speak, right? So I think there's, you know, there's, and interestingly that you mentioned that, I went to a lot of the literature in Africa that informed a lot of this work that we're doing here, because there's not as much on this topic, but there's a lot more that I came across on the concepts of intersectional stigma and stigma experiences in general in the literature in Africa and sub-Saharan Africa specifically. So that's a really great point. And I think that speaks exactly to what I was trying to get at in the questions here, is that co-occurrence is a lot easier to measure than the compounding piece. And it may be that the co-occurrence, it may be that we don't measure a lot of the compounding parts in the quant. I actually think, and I wonder that the qual is going to tell us a lot more if we do it right about the compounding parts, because you get, you know, what we're limited by what we can do with the quantitative data that we obtain in ways that I think we're not limited in the qualitative work. And it's one of the things that drew me to that framework or these approaches. So.
I'm going to throw something out, but please, anybody just speak up. It seemed to me in your qual sample, you have a relatively heterogeneous group. You know, you're interviewing people from many walks of life. My assumption, I guess I would have going into this, would be that some of those people have thought profoundly and deeply and for a long time about these issues, and they will be very articulate, and they will have responses for you, rich responses that are based on a lot of thought on their part. Other people may not have thought about this much before. And that one thing that I found useful and have been using, particularly when it's when we're interviewing a group of people who may not have thought about the issue much before, is to start out with a Likert type general question about whatever you want to drill down on. What it does, more than anything, you can crunch the numbers later on, but what it really does, I think, in the moment is, you know, a 5-point Likert where you agree, you know, strongly agree to strongly disagree. And depending on where they start out, you as the interviewer, they've committed, maybe not permanently. Oh, wow, great. Yeah, well, I kind of came up with it organically in one of our projects before, Deanne, but it's been very useful in that it commits and it allows the interviewer an avenue to pursue the conversation. So it just doesn't get left as, I like it, I don't like it, I agree, I don't, you know, that it will embellish what you can draw afterwards, you know, in your conversation on that topic. So thanks,
great
Deanne.
idea.
I was glad to hear that.
Yeah, that's a great idea. Definitely making note of these suggestions.
And I have another question for you is, it seemed to me that you are really focusing on the negative, the barriers, the stigma, the whatever. What about facilitators? I would want to be equally curious, but I didn't see anything
That's a
that
good point. Yeah.
really spoke to looking at the positive side about what has worked, to improve, to decrease that negative side of the intersection of, these things.
Yeah. I mean, I think that is absolutely something that will improve our engagement in these interviews, and to get, people interested, is to think about maybe even leading with what's worked and then getting into what's not been helpful. I think that's absolutely spot on in terms of how to approach the community specifically as well. When we're talking about the Ozarks, it's extremely insular and guarded. And so to outside researchers specifically, and if it hadn't been for the support of the Missouri Rural Health Association, there's no way I would have been able to get the kind of support to do this study. And so you're absolutely right that I think leading with what has been successful and who can we spotlight would be really a great idea. And just recently, I've been meeting with the Jordan Valley Community Health Center, which is an exemplar of facilitators. I mean, they have community health workers that are working in their staffing. They have, they're not perfect, but they're very much farther along in this process of implementation. And so making sure we sample also, I think that's not only a data, like an instrument piece of like in-depth interviews, but also like making sure we sample from some of these higher resourced FQHCs that are going to have those facilitators and maybe have a lot to talk about, but both are going to be useful, both in both settings.
Well, a question for Deanne then is the, what's it called? The Ed Meets' group. Does he have an opportunity to do that kind of whatever it's called again?
The coincidence analysis?
Thank you, yes.
Yeah, it's a reoccurring group. They're monthly meetings. There's actually 2 meetings a month now because of the different time zones.
That's not what I'm asking. I'm asking, would that help in his study would that approach to analyzing the data?
Yeah, I'm doing something kind of similar using that approach. It was a clinic level looking at PrEP implementation strategies in any of the epidemic counties and looking at which strategies, like implementation strategies, result in the best outcomes. And I'm using CNA for that. We're in the beginning stages. It was one of the EHE supplements
Cool,
from just a little while back, but I think it would, but it would be a different analysis, and they already have the grant. So it could be like after the grant, looking at the data this way as well, and then seeing if it could be applied in future studies.
That's very cool. Thank you for those ideas. That's helpful.
Meredith.
Yeah, it's funny. Phil, one of the comments you just made actually was going to lead into my next question, because I was thinking about your point about strategies for presenting findings to community partners. And I guess I wanted to get a sense of how many, how are either community partners or folks who maybe represent your study of your population of interest, are they already part of your study team in any way? Because I have
some. It's great that you asked that, because I have some funding in my budget for it. And I wanted to do that. And we got a new executive director at the Missouri Rural Health Association. So they were way behind for a period of time in terms of helping us out. There was this period, we got funded in July, and there was 4 months where they were kind of changing over leadership and just were we can't, they kind of had to kick the can down the road a little bit with us, because they were we're just overwhelmed taking on new leadership. But that has, and the Missouri Primary Care Association has been another. The hard part about Missouri also is that we have not a lot of advocacy groups compared to other states. So there's not as many, for example, in North Carolina, there's a lot of harm reduction groups that you can reach out to and talk to. There's just not as many here. So we have to do the recruitment directly in many instances with our providers or with their pull people from the community to come. And so I think that's a great idea to bring in at this stage, especially some folks from like AIDS Project of the Ozarks, maybe some people living with HIV, people living with OUD, people who are family members. The thing that we get a lot of too is like even above it, and I think this may be a product, I know we're running up on time, but this may be a product of stigma, but we actually have a lot more like vocal interest of family members who've lost people and less interest of people who are actually from the community. And I think part of that is stigma, that family members are vocal, like we need to address this issue. And the people who are actively dealing with these issues or even in recovery in Missouri in the rural parts where it's heavily evangelical Christian and like really kind of can be difficult. I think there's more of a quiet approach. It's also the culture there. People don't talk openly about their problems in rural Missouri. So it's difficult to, but that's a great point. I think that's for a community presentation of our data, gearing up for that early on by bringing people on would be a great.
Yeah, bring people on. And I think exactly for the reasons you said, like presenting, sharing findings, even getting people to agree to do interviews might be tricky if you don't have all of that. So yeah, if you've got the folks, I think from the beginning, that'll make a difference.
Yeah, definitely. I'm highlighting that we need to do that now. We need to,
Yeah. It does take a while.
yeah, no, definitely.
Building on what Meredith just said, it may also be useful to have someone involved in the coding team from the actual community. I've done that recently, and I feel like it's really been helpful, especially when then presenting the data to the community. It shows that extra level of not only commitment, but almost validity of the data.
That's a great idea. And I know where I'm going to start. This is really helpful. We have peer support specialists who are credentialed in our state. And I think that they can tap into some of the, they're living in recovery and they go out and they're licensed to essentially be kind of connecting to care for folks. And so I'm gonna reach out to them for that piece. It's very helpful. Thanks.
There's been some great suggestions, and thank you so much for, presenting.
Really appreciate it.
You managed the delay for screen sharing beautifully. And
What can
we'll
you do?
look forward to hearing more from you on this,
Well,
as well as Deanne on her
yeah.
approach on the coincidence analysis.
Well, thank you for the time. Greatly appreciate it. Thank you.
Yep. And